Okay. So, so guys, first we will discuss few questions related to hematopoiesis. Okay, few questions related to hematopoiesis. Okay, so guys, you will tell me what is the bone marrow aspiration site in adults? What is the bone marrow aspiration site in adults? What is the bone marrow aspiration site in adults? So the bone marrow aspiration site in adults is, so it will be a, like active discussion, and we'll be discussing the questions. Okay, and you will write down the answers in the comment section below. The site for bone marrow aspiration in adults is iliac crest. Okay, and the site in children is anteromedial end of tibia. Anteromedial end of tibia. Okay, anteromedial end of tibia. What is the needle? What is the needle that is used? That is used for um, bone marrow aspiration. It is Kala and Lima needle. Kala and Klima needle. Okay, Kala and Klima needle. Okay, so now you will tell me what is the ratio between fat cells is to bone marrow cells. What is the ratio between fat cell is to marrow cells? What is the ratio between fat cells is to marrow cells? So this is a bone marrow cellularity question. What is the ratio between fat cells is to marrow cells? So I guess there is some lag between both of us. Okay. So what is the ratio between fat cells is to marrow cells? What is the normal ratio? It is 1 is to 1. It is 1 is to 1. And the ratio between myeloid and erythroid cells is, very good. It is 3 is to 1. It is 3 is to 1. Okay. And largest number of bone marrow myeloblast precursor cells is promyelocyte. Largest number of bone marrow myeloblast precursor cells is promyelocytes. Okay. Guys, another thing that you need to remember is that this ratio, myeloid is to erythroid cell ratio, it is reversed in megaloblastic anemia. It is reversed in megaloblastic anemia. Okay, it is reversed in megaloblastic anemia. Fine. So just let me know if this speed is fine. If this speed is fine, let me know. So coming to the pluripotent stem cells, what is the CD marker? What is the CD marker for pluripotent hematopoietic stem cells? CD marker for pluripotent hematopoietic. What is the reason for pluripotent hematopoietic stem cells? CD marker. The CD marker is CD34. CD34. Okay. Now coming to the various stages of RBC development. So various stages are, so stem cells form colony forming unit, then pronormoblast, normoblast, and in the normoblast we have early, intermediate, late, reticulocyte and normal. Okay, so just hold on for a second. तो यार मेरी ना अभी क्लास चल रही है, थोड़ी देर में करता हूँ. So these are the various stages of the RBC development. Okay, so guys, we need to know important points in these stages of RBC development. Okay, so you will tell me the hemoglobin, the heme synthesis starts at which stage of RBC development? Heme synthesis starts at which stage of RBC development? Heme synthesis starts at which stage of RBC development? Heme synthesis starts in the stage of pronormoblast. So, Dr. Suman, I will read about it and I will let you know. Okay, I will read about it and I will let you know about the answer. Okay. So the heme synthesis starts in the stage of pronormoblast. The heme synthesis starts in the stage of pronormoblast. Okay, and guys, you have to remember that heme synthesis starts in the stage of pronormoblast. Okay, but hemoglobin is first heme is first detected by Jamesa staining in which stage? Heme is first detected by Jamesa staining at which stage? Heme is first detected by Jamesa staining at which stage? Let's see who can answer this. Heme is first detected. Uh, Guys, I will take approximately half an hour to 1 hour on this session. Okay, half an hour to 1 hour. Okay, so um, so my question was that heme is first detected by GMSA staining. Okay, so we all know that this this heme synthesis starts in the stage of pronormoblast. Okay, so guys, but this heme is first detected. This heme is first detected in the stage of intermediate normoblast. Okay, it is first detected in the stage of intermediate norm. And remember that this intermediate normoblast is polychromatophilic. Polychromatophilic. Okay, and the nucleus is removed. The nucleus is removed at which stage? Nucleus is removed at which stage of a normoblast? Nucleus is removed in the late stage of normoblast. Okay, nucleus is removed. Okay, nucleus is removed in the late normoblast stage. So at late normoblast stage, the nucleus is removed. Okay, and as you know, the reticulocyte and normal RBCs does not have a nucleus. Okay, very good, Dr. Vaishnavi and Dr. Shalam. Okay, and I also want to tell you that this reticulocyte, what is the stain? What is the specific stain that is used for staining of reticulocyte? What is the stain used for reticulocyte staining? What is the stain? So the stain for reticulocyte staining is the stain is supravital stain. Supravital stain. Okay. So this stain is specific for reticulocyte, and among supravital stain, new methylene blue is more specific. New methylene blue is more specific. Okay. New methylene blue is more specific. Okay. So guys, we need to know this corrected reticulocyte count. What is this corrected reticulocyte count? This corrected reticulocyte count is the reticulocyte count into the PCV of the patient divided by average age for PCV divided by average age for PCV. So this is the corrected reticulocyte count. This can come in any of your exam. Okay, this can come in your NEET PG as well. It was a previous AIMS question. Okay. Now coming to the normal reticulocyte count, what is the normal reticulocyte count? The normal reticulocyte count is 0.5 to 1.5%. Okay. So coming to few questions. So in these questions, guys, I will take around 10 seconds break and try to answer them. Okay, we will be very fast in your discussion. Okay, so in this half an hour to 45 minutes, I will want that you gain maximum from this session. Okay, um, because you guys are very busy. I don't want to waste your time as well. Okay, so the common site for hematopoiesis in fetus is liver. Okay, so let us discuss the various RBC indices. Okay, so guys, the mean cell volume is, let me know in the comment section, the mean cell volume. Try to answer all these 5 questions in the comment section. What is the mean cell volume? The mean cell hemoglobin concentration, RBC distribution width, and the normal value of hematocrit. Okay, try to answer this in the comment section. So let's see how many of you can answer this. Okay. So I'm just telling you the mean cell volume is 82 to 96 femtoliter. Okay. The mean cell hemoglobin is 27 to 32 picogram. Okay. Mean cell hemoglobin concentration is 33 to 37, 32, 33 to 37 gram per deciliter. Okay. RBC distribution width is between 11.5 to 14.5. Okay, and the normal value of hematocrit is 45. Okay, so moving forward, and also we need to know important points of RBC distribution width. We need to know one important point of RDW. Okay, so guys, this RDW is used to differentiate between iron deficiency anemia and thalassemia. Iron deficiency anemia and thalassemia. Okay, so in thalassemia the RDW is normal, whereas in iron deficiency anemia the RDW is increased. Okay, so just remember this fact. Just remember this fact. Um, so is this fine, clear? Are you fine with the values? Just give me okay. Just tell me okay in the comment section if you are fine with all these values. Okay, and remember that this hematocrit increases with increase in number as well as size of RBC. Okay, with increase in number as well as size of RBC. Okay, this hematocrit increases with increase in number as well as size of RBCs. Okay, but there is one exception to this rule. There is one exception to this rule. Okay, the exception is megaloblastic anemia. The exception is megaloblastic anemia. Okay, in which the size increases, but the hematocrit decreases. Okay, so coming to the classification of anemias. Okay, so these can be hemolytic anemias, anemia due to impaired production. In hemolytic, we will have due to enzyme deficiency such as D6PD deficiency, due to membrane defect, okay, due to hemoglobinopathies, and they can be antibody mediated as well. In antibody mediated, we have immunohemolytic anemia. Immunohemolytic anemia. Okay. Immunohemolytic anemia. Okay. So osmotic fragility is increased in. Osmotic fragility is increased in which type of anemia? So guys, I want to tell you few points with that RBC cytoplasm is isotonic with. Just let me know this answer in the comment section. The RBC cytoplasm is isotonic with 0.9% NaCl. 0.9% NaCl. Okay, and the hemolysis starts when the concentration of NaCl falls to 0.5%. Okay, but as Dr. Muhammad has said, the answer is C, hereditary spherocytosis. But in hereditary spherocytosis, the hemolysis will start at 0.8%. 0.8%. Okay. Anemia with reticulocytosis is seen in. Anemia with reticulocytosis is seen in. Anemia with reticulocytosis is seen in. So anemia with reticulocytosis is seen in hemolysis. Okay. In hemolysis, there will be anemia. Okay. But reticulocytosis will not take place in any anemia like nutritional deficiency anemia, vitamin B12 deficiency anemia, or aplastic anemia. Okay, so anemia with reticulocytosis will be seen in hemolysis. Okay, extravascular hemolysis causes. Extravascular hemolysis causes. What is the answer, guys? So I will tell you the answer. So guys, these features, hemoglobinemia, hemosideruria, and hemoglobinemia. Okay. So basically these two things will be seen in cases of intravascular hemolysis. Intravascular hemolysis. Okay. So hemoglobin will be released within the blood when the RBC is broken down within the blood vessels. But when this RBC is broken down within the spleen, okay, this hemoglobin will not be released within the blood vessels. Will not be released in your blood. Okay, and there will be no hemoglobinemia or hemosideruria within the extravascular hemolysis. So the answer is decreased haptoglobin. Okay, it is not increased, but there is mild decrease in haptoglobin. Okay, mild decrease in haptoglobin in extravascular hemolysis. Okay, this haptoglobin is also decreased. Haptoglobin is also decreased in intravascular hemolysis. Haptoglobin is also decreased in intravascular hemolysis. Okay, so now coming to the next question. Intravascular hemolytic anemia is seen in all except. Intravascular hemolytic anemia is seen in all except. Let us see how many of you can answer this. Intravascular hemolytic anemia is seen in all except. So guys, in autoimmune hemolytic anemia, okay, in autoimmune hemolytic anemia, it will be broken down the, just wait a second. In autoimmune hemolytic anemia, okay, there will be intravascular hemolysis, okay, because antibodies are formed against the RBCs, and they break down the RBCs within the blood itself. Okay, in TTP also there is microangiopathic hemolytic anemia. Okay, hemolysis takes place within the blood vessels only. Okay, so it will be intravascular, and same is for infection. Okay, whereas in thalassemia, the RBCs will be broken down in the spleen. Okay, so the answer is thalassemia. Okay guys, and also I want to discuss few questions on autoimmune hemolytic anemia. Let us discuss few questions. So in warm type of autoimmune hemolytic anemia, the antibodies are formed. Which type of antibodies are formed? Let me know in the comment section. Which type of antibodies are formed in autoimmune hemolytic anemia? Warm type antibodies are IgG. Which type? Yes. Right. No, Dr. Muhammad. The antibodies are IgG G type. Okay. So just remember this, that in warm, the antibodies are IgG type. Okay. And these are seen in patients with SLE, then CLL, then few drugs also such as methyl dopa, then penicillin. Okay, then cold uh, co- cold type of autoimmune hemolytic anemia. Okay, so it is of two type: cold agglutinin type, and cold hemolysin type. Okay, so in cold agglutinin type, what are the type of antibodies that are formed in cold agglutinin type? What are the antibodies that are formed in cold agglutinin type? Let us see how many of you can answer this. What are the antibodies that are formed in cold agglutinin? Yes, the antibodies are IgM type. Okay, the antibodies are IgM type. Okay, whereas in cold hemolysin type, the antibodies are against the P antigen, P antigen of RBCs, and these are of IgG type. Okay, and these antibodies are also known as Donath Landsteiner bodies. Donath Landsteiner bodies. Okay, Now guys, coming to the next question. Low serum haptoglobin in hemolysis is marked by. Low haptoglobin in hemolysis is marked by. Let us see how many of you can answer. Low serum haptoglobin in hemolysis is marked by. I'm waiting for your answer.
Playing from Himanshu Gupta's iPad.
So, no, Sneha, the answer is not B. The answer is not B. The answer is not B. Not B. So guys, the answer is bile duct obstruction. Okay. So the low serum haptoglobin in hemolysis is marked by bile duct obstruction. Okay. So remember this haptoglobin plus hemoglobin. The haptoglobin plus hemoglobin complex is excreted through bile duct. Is excreted through bile. Okay. Then it enters the enterohepatic circulation, and after that it is excreted through kidneys. Okay. So if this haptoglobin plus hemoglobin concept complex will not be excreted through bile. Okay. So even if it is low, it will appear increased. Okay, because it is not being excreted. Remember that in pregnancy and liver disease, this haptoglobin will be low. Okay, there will be decreased haptoglobin. Okay, there will be decreased haptoglobin. The shape of RBC, is biconcave due to. The shape of RBC is biconcave due to. Let's see how many of you can answer this. The shape of RBC is biconcave due to. Yes. The answer is B. The answer is B. Okay. The answer is B. Spectrin. Okay. So the answer is B. The most common cause of hereditary spherocytosis. The most common cause of hereditary spherocytosis is. The most common cause of hereditary spherocytosis is. Let's see who can answer this. The most common cause of hereditary spherocytosis. Very good, Dr. Priya. The answer is ankyrin. The answer is ankyrin. Okay. It is the most common cause of hereditary spherocytosis. Remember that the spectrin correlates with the severity. Okay. The spectrin molecule correlates with the severity in hereditary spherocytosis. Correlates with severity in hereditary spherocytosis. Okay. And in glycophorin you will never see a mutation in hereditary spherocytosis. And remember that this is the most abundant glycoprotein in RBC cell membrane. Okay. RBC cell membrane. Okay. So coming to the next question, maximum spherocytosis is seen in another simple maximum spherocytosis. What is the most common cause? Most common cause of spherocytosis. Okay. So the most common cause of spherocytosis is autoimmune hemolytic anemia. Autoimmune hemolytic. Okay. So just remember this. The most common cause of hereditary spherocytosis is autoimmune hemolytic anemia. Okay. So bite cells are seen in bite cells are seen in Yes, white cells are seen in G6PD deficiency. G6PD deficiency. Okay, so basically G6PD helps in the formation of NADPH2, NADPH2. Okay, and this NADPH2 reduces glutathione, and glutathione further reduces H2O2. Okay, further reduces H2O2. So once this enzyme is deficient, H2O2 is not neutralized. Okay, and this increase in H2O2 within the RBCs causes their hemolysis. Okay, so and also we also see Heinz bodies in G6PD deficiency. Okay, Heinz bodies are seen in G6PD deficiency. Okay. So guys, HbA2 is HbA2 is HbA2 is HbA2 is. Let's see how many of you can answer this. HbA2 is alpha 2 delta 2. Okay, so HbA2 is alpha 2 delta 2. Okay, and alpha 2 beta 2 is HbA. Okay, normal hemoglobin. Okay, and alpha 2 gamma 2 is fetal hemoglobin. Okay, it is fetal hemoglobin. Okay, and yes. Okay, so one of the most common variants of sickle cell disease, frequently marked by lesser degree of hemolytic anemia and greater propensity for the development of retinopathy and aseptic necrosis of bone. Okay, what is your answer, guys? What is your answer? Yes, very good, very good. The answer is HBSC disease. HBSC disease. Okay, HBSC disease. HBSC disease. Yes, very good, Dr. Karthik Sharma. Uh, so basically, in HBSC disease, there is hemoglobin B, hemoglobin S, as well as hemoglobin C. Okay. So let us first discuss what is the mutation that is seen in hemoglobin S. The mutation that is seen in hemoglobin S is glutamic acid. The glutamic acid. The glutamic acid is replaced by valine. The glutamic acid is replaced by valine at the sixth position of beta chain. At the sixth position of beta chain. So this I have told you because this was a simple fact. Now you will tell me what is HBC. What is HBC? What is the replacement seen in HBC? So you will tell me in the comments. Okay. So as you answer this question, I want to tell you guys, I am also taking free classes. I am also taking free classes on the Unacademy platform. Okay, I am also taking free classes on the Unacademy platform. You can always join my Telegram group. Okay, in which I give you the link for that class. Okay, and you can also find the link on my community post as well. Okay, you can find the link on my community post as well, and on my Telegram group. Okay, so now the in HBC, okay, so this valine, this glutamic acid is replaced by lysine. This glutamic acid is replaced by lysine at sixth position of beta chain. At sixth position of beta chain. Okay, good. So persons having heterozygous sickle cell trait is protected from infection of. Persons having heterozygous sickle cell trait is protected from infection of. So a simple question: these persons having an heterozygous sickle cell trait is protected from infection of Plasmodium falciparum. Plasmodium falciparum. Very good, everyone. Okay. So thalassemia occurs due to which mutations? Thalassemia occurs due to which mutations? So thalassemia occurs due to splicing and frame shift mutation. Splicing and frame shift mutation. So this was a PGI question. This was a PGI question. Okay. Yes. Ham test is done for. Ham test is done for. Ham test is done for. Ham test is done for paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. Okay. So guys, I want to ask you these beta chains. These beta chains are coded by which chromosomes? The beta chains are coded by which chromosomes? And the alpha chains are coded by which chromosomes? These beta chains are coded by which chromosome? Alpha chains by which? Okay, so beta chains are coded by chromosome number 11 and alpha chains are coded by chromosome number 16. Okay, 16. And remember that beta thalassemia major is also known as Cooley's anemia, is also known as Cooley's anemia. Okay, is also known as Cooley's anemia. Okay, so let us discuss few points about PNH also. In PNH, the PNH is due to mutation in which gene? PNH is due to mutation in PIGA gene. Okay, PIGA gene. Okay, and this PIGA gene codes for glycosyl phosphatidylinositol anchoring proteins. Okay, it codes for very good, Sneha and S.A. Ansari. Okay, so it codes for GPI anchoring proteins. Okay, and this GPI anchoring protein bind complement proteins. Okay, complement regulating proteins. Okay, these are CD55 and CD59. Okay, and CD59 is membrane inhibitor of reactive lysis. This is more important. And the other is decay accelerating factor. Okay, as the name suggests, membrane inhibitor of reactive lysis. Okay, so these proteins are basically protecting the RBC from lysis. These are protecting the RBCs from lysis. Okay, so whenever there is deficiency, there is problem in this gene. Okay, there is problem in this PIGA gene, and there is uh, problem in the formation of GPI anchoring proteins. There is problem in the formation of GPI anchoring proteins. Okay, so what will happen? These two molecules will not form properly, and it will result in hemolysis. Okay, so what is the most common cause of death? Most common cause of death in PNH. This is an important question that can be asked. Most common cause of death in PNH. The most common cause of death, yes, very good, Sneha. It is thrombosis. Very good, S.A. Ansari. It is thrombosis. Okay. It is thrombosis of hepatic veins. Thrombosis of hepatic veins. Okay, which is known as Budd-Chiari syndrome. Budd-Chiari syndrome. Okay, guys. So these were few points about PNH. Okay, HbA2 concentration in thalassemia trait is. HbA2 concentration in thalassemia trait is. HbA2 concentration. Hi Adiullah. Hi. Lots of love from India to you. So HbA2 concentration in thalassemia trait is, yes, it is more than 3.5. More than 3.5. Okay. So remember that in thalassemia trait, the concentration of HbA2 increases. Okay, the concentration of HbA2 increases. Okay, and we have already discussed this HbA2 is alpha 2, alpha 2, delta 2. Okay, alpha 2, delta 2, alpha 2, delta 2. Okay. Coombs positive hemolysis is seen in. Coombs positive hemolysis is seen in. Coombs positive hemolysis is seen in. It is seen in SLE. Okay. So basically Coombs test is basically for anything where we have to detect any antibody, where we have to detect any antibody attached to RBC. Okay. And if we just look at the options carefully, antibodies are not formed in PNH or hemolytic uremic syndrome or TTP. Okay, it is in SLE in which the antibodies are formed. Okay, it is in SLE in which the antibodies are formed. So the answer will be SLE. Okay. Cold agglutinin is we have already discussed. It is IgM. Okay, and remember, cold agglutinin disease is seen in infection by mycoplasma, pneumoniae and EBV infections. Okay, so these are the common causes for cold agglutinin disease. Cold agglutinin disease. Okay. So Nestrov test is used in the screening of Nestrov test is used in the screening of naked eye single tube. Yes, very good guys. Okay, so it is naked eye single tube red cell osmotic fragility test. It is seen in thalassemia. It is seen in thalassemia. So basically in thalassemia, the osmotic fragility the osmotic fragility is decreased. The osmotic fragility is decreased. So what happens when the osmotic fragility decreases? When the osmotic fragility decreases, no hemolysis of RBCs takes place, and the black line is not seen. The black line is not seen behind the RBCs, whereas in a normal patient, in a normal person, the hemolysis occurs, and the black line can be seen behind the blood. Okay, of a normal patient, whereas in this patient you see you are not able to identify any black line. Okay, so this was naked eye single tube red cell osmotic fragility test. Okay, HBH is associated with what is the answer, guys? HBH is associated with, yes, very good. It is associated with deletion of 3 alpha genes. It is associated with deletion of 3 alpha genes. Very good. Okay, so deletion of 3 alpha genes is seen in HBH. Okay, so can you tell me what is hemoglobin Barts? Hemoglobin Barts. Okay, and deletion of 4 alpha gene is associated with hydrops fetalis. Hydrops fetalis. Okay, and remember, when there is deletion of 3 alpha genes, there will be formation of beta 4 tetramer. Okay, whereas in deletion of 4 alpha genes, so basically we are talking about alpha thalassemia. In this hydrops fetalis, there will be a tetramer formed of gamma 4 chains. Okay, because in fetus we have fetal hemoglobin, which is formed of alpha 2 gamma 2. Now there is no formation of alpha chains, and the tetramer will be formed of gamma 4. Okay, okay guys, and this hemoglobin Barts is gamma 4. Okay, it is gamma 4. Mutation in which of the following gene is most important in paroxysmal nocturnal hemoglobinuria? Okay, this we have discussed. The mutation in Paroxysmal nocturnal hemoglobinuria is glycosyl phosphatidylinositol. And remember, the most common cause of death in PNH is hepatic vein thrombosis. Okay, so best test for assessment of iron status is, so another simple question, and I will tell you the answer. The best test for the assessment of iron status is ferritin. Is ferritin. Okay. So iron is stored in, another simple question. Iron is stored in bone marrow, liver, spleen. Okay. So the answer is all of the above. All of the above. Okay. So not wasting too much time on easy questions. The earliest sign of iron deficiency anemia is denoted by, the earliest sign of iron deficiency anemia is denoted by, the earliest sign that is denoted by it is decrease in serum ferritin level. Decrease in serum ferritin level. Okay. Normal transferrin is saturated with iron percentage. What is the percentage saturation of normal transferrin? What is the percentage saturation of normal transferrin? It is 35%. 35%. Okay, this is the normal saturation. Very good, guys. Which of the following is important but non-specific for regulation of iron metabolism? Okay, which of the following is important but non-specific for iron regulation? It is DMT1. Okay, this hepcidin, this is a negative regulator of ferroportin. This is very specific for iron. Transferrin and ferritin all are specific for iron. So the answer is DMT1. Okay, so guys, let us discuss few points about iron metabolism. Iron metabolism. Okay, so guys, always remember that this iron is absorbed in the ferrous form. Okay, in the enterocytes, in the duodenum. Okay, so it is always absorbed in the ferrous form. Okay, and this ferrous form is then absorbed inside the enterocyte with the help of DMT1. Okay, and this iron is transported throughout the body in the form of ferric form. This ferric form is the one that combines with transferrin and it is transported throughout the body. Okay, and this conversion of ferrous to ferric form is done by ferroportin. Okay, ferroportin. Okay, and coming to this hepcidin molecule. Okay, so this hepcidin molecule is formed by the liver. It is an acute phase reactant, and it is a negative regulator of ferroportin. It is a negative regulator of ferroportin. Okay, it is a negative regulator of ferroportin. So whenever the hepcidin increases, the ferroportin will decrease. Okay, so this hepcidin increases in patients with, it increases in patients with this hepcidin increases in patients with chronic diseases. So it results in anemia of chronic disease. Okay, so it increases in patients with anemia of chronic disease due to the effect of cytokines IL-1 and IL-6. Okay. Yes, very good, Dr. Shivani. The most common worm causing iron deficiency anemia is, the most common worm causing iron deficiency anemia is, simple question, it is, come on guys, is roundworm. Is roundworm. Okay, or ankylostoma duodenale. Okay, yeah, sorry, hookworm. Okay, so my micro is not as good as yours. Okay, so good, you know this. Okay, So in iron deficiency anemia, the serum iron decreases, the serum ferritin decreases, serum transferrin saturation decreases. Okay, serum transferrin saturation decreases, whereas total iron binding capacity increases. Okay, so we have to know how we will differentiate iron deficiency anemia and thalassemia. Iron deficiency anemia and thalassemia. Okay, in iron deficiency anemia, the RDW will increase. Okay, whereas in thalassemia, the RDW will remain normal, and the other is Metzer index, which is MCV by RBC count. Okay, so remember thalassemia with the word 13, 13 less semia, 13 less semia. Okay, so 13 less semia, and in this, in thalassemia, the Metzer index is less than 13, whereas in iron deficiency anemia, it is more than 13. So these are the two ways by which you can differentiate both of these. Okay, and coming to anemia of chronic disease, okay, we have already discussed IL-1, IL-6. In chronic infection, these two cytokines are released, and these two cytokines will increase hepcidin formation, and this hepcidin formation will inhibit ferroportin. There will be decreased iron within the blood, and it will result in microcytic hypochromic anemia. Okay, so guys, what are the microcytic anemias that you know of? What are the microcytic anemias that you know of? Yes, very good knowledge challenge. That is a good mnemonic. I for increase. That is a better mnemonic. Okay, good, very good. So what? The mnemonic is Sita. The mnemonic is Sita, where S stands for sideroblastic anemia, I for iron deficiency anemia, T for thalassemia, and A for anemia of chronic disease. Okay, so and what is the mnemonic for macrocytic anemia? Macrocytic anemia. What is the mnemonic for macrocytic anemia? For macrocytic anemias, it is the mnemonic is LHMC. Okay, L for lead poisoning, H for hypothyroidism, M for very good, Dr. Shivani. Both of us have read from the same place. Okay, and M for megaloblastic anemia, and C for cytotoxic drugs. Okay, C for cytotoxic drugs. Okay, guys. So coming to few points about sideroblastic anemia. Okay, in sideroblastic anemia, there is difficulty in the combination of iron plus protoporphyrin. Okay, so it results in deficient synthesis of heme. So heme is not properly formed because of this combination. Okay, so when this combination, this iron is not able to combine with protoporphyrin, what happens? This iron gets stored within the mitochondria. This iron gets stored within the mitochondria as ringed sideroblast. Okay, so we see ringed sideroblast. Okay, ringed sideroblast, and so these are ringed sideroblasts, the mitochondria that are seen, iron stored within the mitochondria. Okay, and these can be stained with the help of Prussian blue. They can be stained with the help of Prussian blue, and then they are known as Pappenheimer bodies. Pappenheimer bodies. Okay, and it can be X-linked, then it can be acquired, and it acquired the causes lead poisoning, drugs, etc. Okay, there will be decreased heme synthesis and increase in iron accumulation. So serum ferritin will increase. Serum ferritin will increase. Okay, good. Schilling's test is false positive in. Schilling's test is false positive in. Doc Arjit. So Schilling's test is false positive in. Very good. It is false positive in renal insufficiency. Okay. So in Schilling test we give radio labeled vitamin B12. Radio labeled vitamin B12. Okay. So if the excretion is we give radio labeled vitamin B12. Okay. So if the excretion is less than 8%, if it is less than 8%, okay, then there is definitely uh, then there is definitely a pernicious anemia. Okay, pernicious anemia. Okay, and what we do after this what we give radio labeled vitamin B12 plus plus intrinsic factor. Okay, so if after giving this radio labeled vitamin B12 along with intrinsic factor, even after this even after this even after this the even after this the secretion is not normal. Okay, the secretion is not normal, then it is due to the absorption problem. Okay, then it is due to the problem in absorption. But if it becomes normal, then it is due to intrinsic factor deficiency. Okay guys, clear? सो सबसे पहले हम रेडियो लेबल्ड विटामिन B12 दे देंगे. ओके, एंड अगर वो रेडियो लेबल्ड विटामिन B12 की एक्सक्रीशन नॉर्मल होगी, ठीक है, तो मतलब वो B12 डेफिशिएंसी एनीमिया है. बट अगर उसकी एक्सक्रीशन लेस देन 8% है, तो हम उसका कॉज इवेल्युएट करेंगे, वेदर इट इज़ ड्यू टू डिफेक्ट इन एब्जॉर्प्शन और वेदर इट इज़ ड्यू टू इंट्रिंसिक फैक्टर डेफिशिएंसी. ओके. सो अगर इंट्रिंसिक फैक्टर देने के बाद भी excretion कम है, even if after giving the intrinsic factor the excretion is less, okay, then it is due to difficulty in absorption. Okay, but even if after giving intrinsic factor it becomes normal, तो मतलब intrinsic factor की deficiency है. Okay, so this is basically being excreted within the kidney. Okay, this radio labeled vitamin B12 is being excreted in the kidney. Okay, so अगर हमारे पास renal insufficiency होगी तो ये रेडियो लेबल्ड विटामिन B12 renal insufficiency में बढ़ जाएगा. Okay, so Pappenheimer bodies are composed of what is your answer guys? Very good. So Pappenheimer bodies are composed of iron. Pappenheimer bodies are composed of iron. Okay, so guys मैं ना 15th जनवरी को आई एम टेकिंग अ लेक्चर ऑन सिस्टमिक पैथ. Okay, on Unacademy. So I will give you the links in the Telegram group. The link of my Telegram group is you can search http. You can just search Himanshu Gupta MC. And do join me for the systemic path class. Okay, do join me for the systemic path class. Okay, give me a thumbs up if you will join there also. It will take place at 8 p.m. Okay, कोई thumbs up नहीं दे रहा क्या? So Cabot's ring in RBC is seen in it is seen in acquired hemolytic anemia. Okay, so this Cabot's ring is also seen in megaloblastic anemia. Okay, it is also seen in megaloblastic anemia. Okay, so if possible, okay, uh, you go there and do like follow my profile there. So with this way you will get a notification also ki bhai whenever the lecture will come. Okay, because if more people are there attending the lecture, I become more motivated. Burr cell is seen in 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 uremia. Okay, so Burr cell is seen in uremia, and spur cell is seen in 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 A beta lipoproteinemia. Okay, A beta lipoproteinemia. Okay, so basically in Burr cell, what we have, we have a cytoplasmic projection, the cytoplasmic projections that are regularly spaced. Okay, we have regularly spaced cytoplasmic projections, whereas in A beta lipoproteinemia the cytoplasmic projections are irregularly spaced. Okay, abioantigens are not found in abioantigens are not found in abioantigens are not found in Let's see who can answer this. Abioantigens are not found in abioantigens are not found in just wait a second, um, wait a second. um, okay. Abioantigens are not found in CSF. Okay, abioantigens are not found in CSF. Okay, abioantigens are not found in CSF. Many of you have got this question wrong. The answer is CSF. Okay, helmet cells are characteristic of helmet cells are characteristic of helmet cells are characteristic of Very good, Dr. Naveen, Dr. Priya. So the helmet cells are characteristic of hemolytic uremic syndrome. Okay, so these are also known as schistocytes. Schistocytes. Okay, these are seen in hemolytic uremic syndrome. Okay, so guys, you need to remember a pentad in macroangiopathic hemolytic anemia. You need to remember one pentad. Okay, and it is fever, then thrombocytopenia, thrombocytopenia, fever, then renal renal insufficiency, then CNS problems, and another is, what is the fifth one? What is the pentad that is seen in microangiopathic hemolytic anemia? CNS abnormality, renal insufficiency, fever, thrombocytopenia, and MAHA. Okay, MAHA, macroangiopathic hemolytic anemia. Okay, very good. So Howell Jolly bodies may be seen after, another simple question, Howell Jolly bodies may be seen after splenectomy. May be seen after splenectomy. Okay, it can be seen in hemolytic anemias, then it can be seen in megaloblastic anemia. Okay, so splenectomy is very important. Howell Jolly bodies are seen after splenectomy. Okay, so let us just revise the various cells. Okay, these spherocytes are seen in autoimmune hemolytic anemia, then hereditary spherocytosis, then burns, then blood transfusion reaction. Okay, this burr cell is seen in which disease? Come on, guys. Dr. Ganeshan Ramaswamy, first year MBBS. डॉक्टर अरिजीत इज सेइंग वेरी करेक्ट यार. अभी रिलैक्स करो, अभी थोड़ा बहुत पढ़ लो, जो भी पढ़ना है बना दूंगा उसके ऊपर भी वीडियो. ओके, दीज हेलमेट सेल्स आर सीन इन माहा. ओके, मैक्रोएंजियोपैथिक हेमोलिटिक एनीमिया. ओके, योर टारगेट सेल इज सीन इन थैलेसीमिया. इट इज सीन इन थैलेसीमिया. ओके, I will make a video on first year MBBS, don't worry. Okay, so burr cell will be seen in uremia and liver dysfunction. So you are joining first year, or are you joining first year, or you are in first year? So teardrop cell is seen in myelophthisic anemia. Okay, teardrop cell is seen in myelophthisic anemia. Okay, and Howell Jolly bodies we have discussed. It is seen after splenectomy, then it can be seen in hemolytic anemias. Okay, Pappenheimer bodies are seen in sideroblastic anemia. Okay, sideroblastic anemia, then iron deficiency anemia. Cabot ring is seen in megaloblastic anemia. Okay, and basophilic stippling is also seen in various causes. Okay, megaloblastic anemia. Okay, so coming to the last question, erythropoiesis in adults occur in. The answer is erythropoiesis in adults occur in. Erythropoiesis in adults occur in. Flat bones. Very good. Okay, so I wanted to tell you that this intrinsic factor plus vitamin B12 is absorbed maximally in the terminal ileum through tubulin receptors. Okay, and the most common worm causing vitamin B12 deficiency is Diphalobothrium latum. Okay, and what else? Okay, so basically, tell me what is the narrated form of aplastic anemia. The narrated form of aplastic anemia is known as Fanconi's anemia. Okay, so this is an inherited form of aplastic anemia, and remember, everything will decrease: the RBC, TLC, platelet count, and the splenomegaly is absent. Okay, and on bone marrow aspirate, we will see a dry tab. Okay, and this dry tab is also seen in hairy cell leukemia. Okay, severe aplastic anemia, what are the criteria? The bone marrow cellularity should be less than 25%, and besides these, two criteria should be present. The corrected reticulocyte count should be less than 1%. In ANs, the absolute neutrophil count should be less than 500, and the platelet count should be less than 20,000. Okay, platelet count should be less than 20,000. And in very severe aplastic anemia, this neutrophil count criteria is less than 200. Okay, so last question for today is, so before telling you the question, I will give you the link of the Telegram group. So what you can do, you can join my Telegram group, and you can follow my profile also. Okay, Okay, this is the link of the Telegram group. Okay, and what is hereditary pure cell aplasia? What is the hereditary form of pure cell aplasia known as? Hereditary form of pure cell aplasia is known as. Last question for today. It is diamond Blackfan syndrome. This diamond Blackfan syndrome. So guys, this was all for today. Meet you on 15th. Okay, and do stay updated with me on my Telegram group. Bye bye. All the best, guys.